Yes, ma'am. Yes.
Yeah, good morning, everyone. Many thanks to True Education Group for making this talk possible, and thanks to Dr. Nitish Jain for helping us relay as well. My sincere thanks to our esteemed Dr. Devanathan sir, Dr. Vikram, Dr. Govind Rajan, Dr. Karthikeyan, Dr. Maheshwaran, and Dr. Vinod Khanna. Um, and a big hi to Dr. Sanjay Sinha, Dr. Arun, and Dr. Sanjay Pandey. So, the topic was vault prolapse. Instead of way forward, I put the best way backward. You might be wondering why it's so. It's because of the fact that it has come further down. We want to put it the best way back to its original position. And what would be the correct choice of procedure? Do we need to do it at all? When we do it, do we need to address the situation? And if at all, what are the best possible ways we can address the situation with least complication? And what is the evidence out there? This is what we are going to look at. And time permits, we will look at a video as well. So why talk about this? We definitely know that pelvic organ prolapse substantially affects the quality of women's life. It's not life-threatening, but nevertheless, it causes significant physical, psychological, and social distress for a patient suffering from prolapse-related symptoms, accompanied both by bladder and bowel-related dysfunction. Needless to say, the sexual dysfunction and the pelvic floor dysfunction, which goes hand in hand with it. And we know that the most consistent risk factors, despite geographical boundaries, demographics, are vaginal childbirth, advancing age, increasing body mass index, and a history of prior hysterectomy, especially if done in an age less than 40 years, for indications which could be prolapse related or otherwise as well. And we need to evaluate and offer treatment to the women only if they report any borders not on a screening the mass and getting these patients out for treatment. They should have other symptoms. And we do know that there are effective conservative management options such as vaginal pessaries and pelvic floor physiotherapy, especially for stage 1 to 2. Beyond that, physiotherapy doesn't work. And surgery is generally reserved for patients with bothersome symptoms who have at least stage 2 prolapse. Anatomical guide for even a beginner: if something is beyond the introitus level, we need to operate. Simple as that. Women's lifetime risk of history of surgery for pelvic organ prolapse is to the order of 1 in 5. So if I have 20 women, I'm going to operate at least on one of them. So there is a 20% chance I will be operating on 100 cohort patients. And it accounts for nearly 20% of the hysterectomies which are done, especially in the postmenopausal women. The statistics will be slightly high in our patients, but we are seeing declining evidence of pelvic organ prolapse, not so what we used to see when we were in a PG days. Nevertheless, we do see a lot of vault prolapse these days because of the hysterectomy which has been done for softer indications. And we all know POP is nothing but a downward descent of the female pelvic organs into or through the vagina. These are complex prolapses. I'm not going to dwell into the other kinds of prolapses. I'm going to pick only on vault prolapse. These are complex prolapses, and we definitely need a multidisciplinary team to evaluate as well as to look after these patients, especially if they are having repeat continence surgery. They are having a repeat same site prolapse surgery. For instance, an anterior wall prolapse of the vagina, namely a sister seal, is the notorious compartment to recur again. Nearly about 60% of the patient can have recurrent prolapse in their lifetime, and more than stage 2, warranting surgery in 30% of that cohort. And that is a significant number. And the usual recurrence is within 7 to 10 years. So that should be dealt with by a specialized team, if not a specialist who deals with it on a daily basis. And if they have coexisting bowel problems, and if there has been a prolapse mesh repair which has been done, or a prolapse mesh related problems, and they're considering surgery but may wish to have children in the future. So the key personnel who are involved in the management of these patients are a subspecialist in urogynecology or a urologist with expertise in female urology, a urology or a continence specialist nurse, especially with incontinence related problem, definitely a pelvic floor specialist physiotherapist, both for the pre-op evaluation, management, as well as post-operative rehab, a radiologist with expertise in pelvic floor imaging. You will see that the transperineal ultrasound is a very good modality of assessing the prolapse in all the three compartments, mainly the anterior, the apical segment, as well as the posterior segment, and to rule out a large enterocele as well. Colorectal surgeon, if at all the patient presents with obstructive defecatory symptoms and in the absence of an obvious rectusy. And a pain specialist with expertise in managing pelvic pain, because most of this pain could be related to sexual dysfunction, either because of vaginal atrophy due to dyspareunia, or because of a shortened vagina due to the mesh related complications, or because of the prolapse itself. These patients should also have access to psychosexual counseling, chronic pain management, bowel symptom management, and neurological evaluation and rehab, because as we understand, multiple vaginal births, traumatic vaginal deliveries, especially obstetric forceps delivery, can result in pudendal nerve damage, which can cause laxity of the vagina and the attendant organs, along with bladder and bowel dysfunction as well. So how do we prevent and protect this from occurring? We all know McCall's cultoplasty at the time of either a vaginal hysterectomy or purse string suture of the uterosacrals higher up during a laparoscopic hysterectomy is the best way to prevent the occurrence of wall prolapse. In a study, it has been found, it is done, there is a significant reduction in the occurrence of wall prolapse to the order of 70 to 78%. And enterocele presence, when you're doing a vaginal hysterectomy, if you're at the end of the vaginal hysterectomy, the completed sutured vault lies within 2 centimeters of the introitus, you need to reposit that vault back into the pelvis above the level of ischial spine with a sacrospinous fixation suture. Understand that this sacrospinous fixation is a prophylactic measure and not a corrective procedure for wall prolapse, because it is done at the time of vaginal hysterectomy to prevent the recurrence of a wall prolapse in the future. And some people might argue that leaving the cervix as a fulcrum in the stump will prevent future prolapse, but we know from scientific literature, the current evidence is against the recommendation of a subtotal hysterectomy with a view to prevent wall prolapse at the time of a hysterectomy. So when the patient presents with a wall prolapse, we need to have a thorough assessment and record the presence and degree of the anterior, central, posterior compartments. The POPQ, though it's boring, it is mandatory, one, for uniformity of communication across specialties, uniformity of assessment and evaluation and grading of the prolapse, both preoperatively and postoperatively. It is a prognosticating method to understand whether this patient will have significant reduction of symptoms postoperatively, and also for research and audit purposes. So we do not have an escape mechanism from the POPQ system. Assess the activity of the pelvic floor muscles at the same time. Do not oversee the vaginal atrophy. If you're going to use a mesh, estrogenize the vagina thoroughly before putting a mesh and continue the topical estrogen postoperatively to avoid mesh extrusion, erosion, and exposure related complication. Rule out a pelvic mass or other pathology, because in elderly patient, an ovarian mass could be the reason of the wall prolapse, which is appeared suddenly. We always dig deeper. We just don't satisfy ourselves when the woman presents with prolapse. We need to find out whether there are attendant coexisting symptoms which are bothersome, which are related to the neighboring organs, namely the bladder or the bowel. So investigate whether the patient has urinary symptoms and for which whether we need to consider a surgical intervention. Always inquire about fecal incontinence. Beware that these patients are having the prolapse because of a traumatic vaginal delivery. They might very well have an anal sphincter defect following a complete perineal tear or a missed third degree tear, which has happened or been sustained at the time of vaginal delivery. A prompting and a routine questioning about fecal incontinence with relation to fecal urgency, squeeze pressure, fecal urgency, associated incontinence to form stools, liquid stools, and flatus, and continuous passive soiling or unable to clean themselves would be certain markers towards whether this patient has had fecal incontinence. Definitely inquire about the pain and symptoms that are not explained by examination findings. Many a time, when we examine this patient, patients say it is really bothersome, especially when they are sitting on the toilet. They feel there's something coming and obstructing. We put the patient on a dorsal supine position and examine, and we say, oh my God, there's nothing. You go home and do pelvic floor exercises. Maybe this is not the position which will reveal the degree of prolapse. If you're not able to see the prolapse, but the patient still complains they are really bothered by the symptoms, ask the patient to sit and squat, or ask the patient to stand up with a leg on a footstool and ask the patient to bear down like an Valsalva or cough. Then you might be able to see the bulge which they are complaining of. If we do not do these steps, our assessment of the prolapse is not complete, and we cannot document saying that there is no prolapse. So what directs our management? It's definitely the woman's preferences, the site of the prolapse, lifestyle factors, comorbidity, including whether there is a cognitive or physical disability for that particular patient, definitely the age of patient, desire for childbearing in the future, previous abdominal or pelvic floor surgery, benefits and risks of individual procedures tailored to the need for the patient as well. Irrespective of whether we adopt a surgical or a non-surgical intervention, losing weight for the patient is paramount because it can definitely ease off the severity of symptoms as far as the prolapse is concerned, or even the urinary incontinence symptoms is concerned. Minimize the heavy lifting for the patient, especially if they are carers to people who are dependent. They might have a spouse who's recently had a stroke and therefore the wall prolapse could have been precipitated, or patients who do manual labor, or even healthcare professionals like nurses who are carers for elderly people. Prevent or treat constipation, which could be a precipitating factor for the wall prolapse because the person has learned to strain at stools and thereby the wall prolapses happened. Definitely topical estrogen, its period. Consider vaginal estrogen for women with pelvic organ prolapse and signs of vaginal atrophy, which most of our women are. And consider an estrogen releasing ring, which are available for the patients who cannot apply the cream or not physically able to do it or have cognitive dysfunction as well. But beware, you see them on regular follow-up. And if there is any sign of postmenopausal bleeding, which might not be the case in a wall prolapse, investigate them as you would do for a postmenopausal bleed. Do not assume it's due to the vaginal atrophy. PFMT, which is pelvic floor muscle therapy, only recommended in stage 1 and 2 as evidenced by the POPPY trial. Beyond that, it's not going to work. They say anywhere between 12 to 16 weeks every day, supervised by a specialist trained in pelvic floor physiotherapy, not just a YouTube link or a piece of sheet which says how to do the exercises. Nobody understands how the patient does. Patient herself doesn't understand whether she's using the correct muscle and toning them up. Non-surgical intervention, definitely treat the vaginal atrophy with topical estrogen. Pessary is known to be very good in certain cases which are not operable or not suitable for surgery. There are two types where we have a gel horn and a shelf pessary. These are available. Describe complications including vaginal discharge, difficulty removing the pessary, bleeding, and pessary expulsion. See them at least every 6 months, especially now in the COVID. We warn them about the signs and symptoms. We say it's okay for you to come even a month or two later. Do not expose yourself to these possible infections for the pessary change. We know when we treat, prevent, or correct prolapse, vaginal apex is the keystone. The fulcrum, which is the uterus, is knocked off. The attachment of the cardinal ligaments, the uterosacral ligaments, to the fulcrum is either damaged or cut off, which is why the apex drops. So hysterectomy for a vaginal prolapse is just kind of punishing the victim, whereas the original problem was in the support system. If we corrected the support system, maybe we didn't need to have to do a hysterectomy in the first place. So the whole shift in paradigm of us is that a treatment for prolapse is just vaginal hysterectomy is not good enough. We have to correct the apex by apical suspension, and vaginal hysterectomy is a component to facilitate that apical suspension. If we are able to apically suspend without having to do a hysterectomy in a patient who's requiring such a procedure, might as well do it. But the cornerstone of any treatment of uterovaginal prolapse is apical suspension. And anterior and posterior walls will fail if we do not apically suspend, which is we see in terms of a isolated cystocele repair. If they have not done a central stitch to the cardinals or the cervical paracervical tissue or the vault area with the uterosacrals, there will be a cystocele which will recur within 2 to 3 years. Surgery for prolapsed vaginal vault. The proponents for vaginal surgery are that they have decreased operative time. Definitely a sacrospinous fixation takes only extra 15 to 20 minutes. Decrease incidence of adhesion formation. You don't go inside the peritoneum, and quicker recovery time because there is no abdominal scar. Abdominal surgery is indicated if there was a failed previous vaginal approach. For any de novo vault prolapse, you want to get it right the first time. So this has become the gold standard. Any patient with a short vagina, young patients with advanced prolapse, and with other coexisting conditions. You also consider obliterative procedures like our age-old Leafold's colpoclysis, especially in elderly patients who are not suitable for any of these prolonged procedures. You can obliterate the vagina. You'll be surprised that this particular procedure has a success rate of 93 to 98% because there's nothing through which the uterus or the vault can come out. It's completely obliterated. You just have a dimple in the vaginal area. But beware that you make sure that there is no chance of malignancy in the patient at all. Vaginal surgery, we did discuss the role of preventive scaldoplasty. This might not necessarily be a treatment procedure, but grade 3 evidence suggests that ileococcygis fixation as well as scaldoplasty are good enough interventions without major complications for even treatment of a vault prolapse where you cannot think of abdominal procedures. Sacrospinal ligament fixation, definitely, and high uterosacral ligament suspension and iliococcygeal facial suspension, which we've already discussed. Abdominal repairs, abdominal sacrocolpopexy. We also do a peritoneal, transperitoneal, high uterosacral ligament suspension through the laparoscopic approach, which can be done at the time of laparoscopic hysterectomy to obliterate the pouch of Douglas, so there is no enterocele and thereby no apical descent. So why sacrospinous colpopexy? It's also known as vaginal sacrospinous colpopexy or sacrospinous fixation. Basically, the vault is attached to the right side sacrospinous ligament by two non-absorbable sutures. People do even bilateral fixation. There is no need that you need to do a bilateral fixation. The argument for bilateral fixation is that the vagina can be skewed to one side. Nevertheless, a single unilateral, usually right-sided fixation, because our dominant operating hand is on the right, can be done to the right side itself, and it's as good as bilateral fixation. It's quicker, it's cheaper, and faster return to normal activities. Abdominal sacrocolpopexy, by a cohort study of various meta-analysis of RCTs, definitely become the gold standard compared to vaginal sacrospinous colpofixation, because of the lower rate of apical recurrence afterwards, even after 7 years. Higher success rate to the order of even 90%. Lower postoperative dyspareunia, because the vagina is not skewed to one end and there's no shortening of the vagina. No significant difference in the reoperation rate for prolapse. That is very, very important. This is how the sacrocolpopexy mesh looks like. We create a Y-shaped mesh with your macroporous 75 micron polypropylene mesh, permanent mesh. Anchor it to the anterior and posterior walls of the vaginal vault, which has descended. Pull it up without tension. Anchor it on the anterior sacral longitudinal ligament, especially below the promontory, around S1, S2, S3 area, with ethibond sutures with a non-absorbable suture, or your ProTac if you're doing a laparoscopic or a robotic surgery. So we basically elevate the vaginal wall to the sacral area utilizing a mesh bridge. Any approach can be used. It may change the vaginal axis if you do it to the promontory, so lay it on the sacrum and suture it. 90% success rate can be evidenced and may be done with cervical preservation as a cervicopexy. Mesh erosion around 3 to 5% high. Concomitant surgery. There will be a further slide, so beware if you're doing a hysterectomy and then doing it, because you've opened up the vault, there is a risk of mesh exposure through the vault, mesh extrusion and erosion. So that is the reason we retain the cervix if we are doing a hysterectomy, and anchor the mesh to the stump of the cervix and then put it onto the sacral longitudinal ligament. This is how it's going to be lying on the thing. You can see from the very picture, it is on the anterior sacral longitudinal ligament. Of course, we need to be aware that the fact that you have the rectum and the sigmoid, rectosigmoid lying behind, the ureter of the right side will come in very close contact. So lateralize the ureter, use a epiploic stitch to retract the rectosigmoid. That will take care of both the vital organs, which will not be damaged during the time of the procedure. It's fairly a bloodless surgery if you're on the right plane, and very good operative times if you're well versed with the anatomy and if you're lucky enough that there are not many adhesions. So definitely a gold standard procedure, and if it's done in the right hands, very less blood loss, shorter lengths of stay, and operative times are comparable to even open surgery if you do it robotically, if you're used to doing it on a regular basis. This is just a comparison of robotic sacrocolpopexy and open abdominal sacrocolpopexy. As you can see, a slight increase in operative time is there, but definitely there is decreased length of stay, and the estimated blood loss is definitely lesser. So it can be performed. And you notice that 50% of them also have a concomitant hysterectomy, may be explaining the increased operating time as well. There is not significant difference between laparoscopic and robotic procedures. The robotic procedure definitely useful if you are doing a patient who is morbidly obese or with multiple adhesions or with comorbid conditions, where this could be an added advantage. So with regards to robotic sacrocolpopexy, 13 studies were selected for this. The combined estimated rate of mesh exposure, like for abdominal sacrocolpopexy done the open way, was about 4.1, and only mesh revision reoperation was done in 1.2 of the patient. Not all mesh exposure extrusion will need surgery. Some of them will just have to have topical estrogen and excision of that portion of the mesh which is extruded. Obliterative procedures, we have discussed this at the beginning, where we remove most of the vaginal epithelium within the hymenal ring posteriorly and up to 0.5 to 2 centimeters from the external urethral meatus anteriorly. So you cannot take that portion within the urethral sulcus. Who are the candidates who will benefit? Elderly, frail women who do not have any inclination to be sexually active, multiple comorbidities who are not making them suitable for surgery, not willing for extensive repair, need betterment of self-image, corrects the prolapse definitely, and improves the appearance at the genital hiatus. Benefits over other procedures: shorter operating time, much less blood loss, lesser complication rate, speedy recovery, good term, long-term recovery, low recurrence rate, as effective as greater than 93%. So there's no recurrence with this. There is known to have increased incidence of urinary incontinence, and if we leave the uterus or without proper investigation, there is a potential that they could end up having endometrial carcinoma, because there's no way the blood can escape and we have obliterated the area and we could miss an endometrial pathology. So if we decide to discuss surgery and the patient opts for surgery, these are the different things which we need to discuss with the patient. Discuss all the options and discuss the benefit and risk of each procedure. Also document, communicate, and consent the risk of recurrent prolapse, the uncertainties about the long-term adverse effects because of mesh-related procedures, difference between the procedures in terms of anesthesia, hospital stay, surgical incision, and recovery period, and role of intraoperative prolapse assessment in deciding the most appropriate procedure. This is why when I consent, I always write examination under anesthesia and so and so and so procedure, because I might need to include some other measures at the time of procedure, and I cannot be 100% certain as to what compartments need site-specific repairs. Definitely an incorporated problem is assessment and the debate about whether we do a prophylactic surgery for continence at the time of wall prolapse repair with an intention to treat. And we all know that the stress urinary incontinence can be revealed or occult. The way we find out in the presence of wall prolapse is put a pessary or a swab and reduce the prolapse and conduct urodynamics. If the patient has stress urinary incontinence at the time of urodynamics, go ahead with concurrent procedure. The concurrent procedure can be a midurethral sling after the correction of wall prolapse, or even a Burch-Kolpow suspension. But beware of the hypercontinent state, which can become a problem after Burch-Kolpow suspension, and the about indwelling catheter and retention and a temporary need for self-intermittent clean catheterization post-operatively in either of the cases. And with regards to obvious stress incontinence, either procedures can be offered. If none of these are evident, do not offer as a prophylactic measure, because you will end up having retention of urine and the need for indwelling catheter. And anyway, 1 in 20 patients will somehow need a continence procedure, which can be done as a phase 2 procedure, and that should form part of counseling and consenting. This is what we have discussed in the slide. Discuss the possible complication and the lack of long-term evidence and the effectiveness of the procedure. There is a wonderful patient information guide which we have to discuss with the patient with pictorial representation. It's like a patient decision toolkit which we can go through with the patient, and this are the options, these are the benefits, this is what you will expect, and these are the possible complications. You can choose which one you want. I would recommend this. What is your choice? That would be a better way of doing it. I've just given a ranking for this with regards to the success rate. Sacrocolpopexy, staying gold standard, will be about 78 to 100%. Most of the studies quote about 90 to 95%. Sacrospinous fixation, 1 in 3 will need a recurrent procedure. If they recur after failed sacrospinous fixation, there is no role for vaginal procedure. Go for an abdominal sacrocolpopexy. High uterosacral ligament suspension is about 82% success rate. The quotes have been as high as 95%, but there are implications of major complications associated, especially if you're not trained. This is from Bob Schultz in the US, who does it on a regular basis for the last 15 years. Their center's rate of ureteric complications are to the order of 10 to 11%. So if a center which turns out volumes can have that level of ureteric complications, we need to be aware this is not a procedure to be done by somebody who has done 1 in 3 years. Regarding the complications of abdominal sacrocolpopexy, mesh erosion about 10%, bowel injury about 2%, sacral myelitis, especially if you hit at the intervertebral disc, or use a lot of diathermy in that area, you causing ischemic necrosis of the blood supply, especially around the intervertebral disc, can cause problems there. Severe blood loss, especially if you've not taken care of the median sacral vein and the plexus around that area, can be very difficult to control because it's a venous ooze. Recurrent surgery for pelvic organ prolapse because of the enterocele, which can happen due to the fixation which we do, and recurrent surgery for SUI to the order of 5%, which I've already told. Nearly 16% of the cohort who undergo abdominal sacrocolpopexy can have a resurgery done in the future. One category, 5% for mesh-related problems. One category, another 5% for a possible pelvic organ prolapse, especially an enterocele, and another 5% requiring surgery for continence maintenance. With regards to SSF, recurrent prolapse to the order of 30%, which is significantly high, in considering a procedure where we undertook the procedure for the primary correction of the wall prolapse. Postoperative buttock pain can be to the order of 20%, sciatic pain to the order of 10%, and partial ureteral obstruction again to the order of 6%. Complications of high uterosacral ligament suspension, as I said, ureteral injury, bleeding, small bowel injury, need blood transfusion, blood and urinary infection. So to guide us as regards to the tips when doing the procedure, if the patient is sexually active, choose abdominal sacroplexy. For a failed vaginal procedure, choose abdominal sacrocolpopexy. If the wall prolapse is primary treatment, do sacrocolpopexy. Do not do concurrent hysterectomy. And if you want to do, leave the cervical stem so you do not end up with mesh erosion. Avoid excess energy at the vault area to the section of the bladder so that you do not have a hole in the vagina and thereby a vault erosion. Keep ureteral lateral. Take epiploic stitch to deflect the rectosigmoid area. Make sure you make the area on the anterior surface of the sacrum blood-free. Beware the median sacral vein. And retroperitonealize the mesh completely so you do not end up having mesh-related complications. With regard to sacrospinal fixation, avoid when vaginal length is less than 6 centimeters because the repositioning with the suture, especially the permanent suture, would be under tension and there will be a tearing of the vaginal tissue. Stay 2 centimeter medial to the ischial spine on the sacrospinous ligament. If you go much more medially, you will definitely hit at the nerve and that is going to cause buttock pain. If there is buttock pain, patient will present immediately post-op and that pain is going to last for at least 8 to 12 weeks and it will get better only after that because of the stitching there. Keep to lateral aspect of the rectal bar of fat so you don't enter the rectum or the vascular area. Use non-absorbable sutures for the suspension, otherwise it will break off. High uterosacral ligament, stay at the dorsal part of the uterosacral ligament, otherwise you will include the ureter. The further you come down, the further closer the ureter is. Every bite on the uterosacral ligament, you need a cystoscopy to be done to make sure you do not have kinking of the ureter at that part. Post-operatively, Pain can be there. There can be vaginal problems, urinary problems, bowel problems, and symptoms of infection. So you need to take a detailed assessment and history of the same. If you suspect mesh-related complication, take a history of all past procedure for prolapse or incontinence using the mesh date type of mesh. Use a proper validated questionnaire. This is also available on the websites. Pain questionnaire. Do a thorough vaginal examination to assess whether mesh is palpable, extruded, or exposed. Localize the pain and its anatomical relationship to the mesh. Rectal examination to assess for any possible presence of mesh, perforation of fistula, and a neurological assessment to assess the distribution of pain, sensory alteration, or any muscle weakness. If you suspect a mesh complication, do a EUA if there is only a vaginal erosion, cystoscopy if there are bladder symptoms, sigmoidoscopy if there are bowel symptoms. For any other imaging, do a transperineal ultrasound. MRI is useful if the patient complains of mesh, especially with persistent backache or a low-grade fever where you suspect a mesh infection and an intervertebral disc inflammation or a sacral myelitis. Same way with CT, but MRI would be a preferred method. Can you hear me?
Yes, ma'am, you're audible.
Yeah. Select patients for HUSL and SSLF, whether you have to differentiate between high uterosacral ligament suspension or choose the patient for sacrospinous fixation. This is at the time of vaginal hysterectomy, so we are not doing a wall prolapse repair here. If the vagina is shortened, you cannot do SSLF, number one. If there is already a concomitant anterior repair, I would prefer to do a high uterosacral ligament fixation at that point of time, because of the fact that SSLF will create an increased chance of anterior compartment prolapse in the future. So if the patient has a significant anterior compartment prolapse and if it's a shortened vagina, then I would not do a SSLF for prevention of wall prolapse in the future. What is your take on uterus preserving pelvic floor repairs? Now, when I assess a prolapse, what is the first thing coming out? What is the length of the cervix? If the first thing coming out is the cervix, this is an apical segment prolapse. And for apical segment prolapse, if there is no cervical elongation, we can conserve the uterus. For anterior compartment prolapse and posterior compartment prolapse, there is no indication for a hysterectomy if you want to do a compartmental repair alone. So uterus can be well preserved without compromising the repair integrity for both the anterior and the posterior compartment prolapse. But if we determine that we have an apical prolapse and the cervical length is elongated, then we'll have to do a hysterectomy. I hope that answers that query.
Go in, sir. Next.
Okay, exactly the sutures taken or the vaginal vault end. I take normally 4 sutures in the anterior vaginal wall with the mesh, and that would be a PDS suture, which is a delayed absorbable suture. I don't use a non-absorbable suture at the vaginal end because of the risk of sinus formation, risk of foreign body granulation tissue, as well as exposure and so on and so forth. And posteriorly 3 to 4 sutures. Go posterior as back as possible to anchor to the vault. So you can make the Y into a cylindrical tube at the vaginal end. And at the top, you use either ethibond suture, which are completely non-absorbable suture. The reason why proline would not be preferred is the knotting capacity, especially deep in the pelvis. But if you're comfortable with that, that's okay. Ethibond, the way we can do it with the knotting, and definitely you can see the integrity of the holding of the sutures very well. Not more than 2 sutures on the sacral end is necessary.